Not yet. We'll get there. That's okay because it's the third one and we have the first two. So
Okay. And do you know?
Everybody tap their microphones.
One at a time.
You got them all? Okay, cool. Good. Welcome to another meeting of the Green Mountain Care Board. The only announcements for today are the meetings for next week. Tuesday, due to town meeting day, we will not have any board meeting. On Thursday, we have two subjects we're going to discuss. The first is an introduction to the concept of evaluation measures that might be used in association with payment reform pilots. And Richard Slusky and I will lead that discussion, give a presentation, and we will all take part in a discussion of that. And Con Hogan will make a presentation on the hospital budget process and some recommendations around the next year's hospital budget process. We have two sets of minutes to approve today. Minutes of both from Thursday, February 16th. The first are the minutes of our regular board meeting that day. I guess we should take these separately. So I would entertain a motion for the minutes of the regular board meeting on February 16th.
So moved.
Second.
All in favor?
Aye.
I guess I should have asked for questions or changes, but I didn't.
I'm abstaining.
That makes sense, Al. Next, we have the minutes of the special board meeting at which we heard from the three consultants who are helping us with payment reform design relative to the exchange. And I would entertain a motion for their approval.
So moved.
Second?
Second.
Any questions or comments? All in favor? Okay, thanks. So let's get to today's
Yeah.
agenda.
I abstain again, just to let you know.
Thank you, Al.
You're welcome.
Good reason.
So our first item on our agenda today is further discussion of exchange benefits, and we have Robin back here, and Lindsay's here as well to help with us. And we have Kate Brzezinski on the phone. Do we have anyone else on the phone?
yes, Julie Pepper from Wakely Consulting is also on the phone.
Okay, great. And Robin, I assume you'll lead off the presentation?
Yes,
Take it away.
I will walk you through the morning or afternoon, whatever time of day it happens to be. I've been in the legislature all morning, so I'm a little bit in a vortex. So.
Welcome to the real world.
On like 3 different topics, so just name your pleasure of topics. But today we're going to talk about benefits. We're going to talk again about the Vermont Health Benefit Exchange. And let's see, can I make this move?
So there's 3 sets of slides in front of you. You want the ones with Robin's name on them.
Yes, so we didn't consolidate everything into one document this time, so I'm going to start with the slides that have my name on, then we're going to transition to Kate, and then we're going to transition to Julie, and then it's coming back to me. So we won't go through all of my slides to start. So
Robin,
what?
do you have an extra set of yours?
Coming down to you,
Coming
Con.
down.
Thank you. Great.
And while we're interrupted, I think Robin was going to say something about Con.
Absolutely.
Oh.
I was just getting to that.
Thank you, Robin.
I understand that Mr. Hogan is the recipient of the NAP Award, so I wanted to congratulate him
Thank you.
on that honor.
All right.
Way to go, big guy.
Oh, boy.
You'll make it through the day.
No, I
You
think
will,
so.
you will. This is the little bit of an agenda that I have for you for today. So we're going to start with a brief review of the exchange benefit decisions versus the Green Mountain Care benefit design. We're going to preview questions for discussion later. We're going to review the federal essential health benefit guidance. We're going to talk about prior authorizations as you requested last time. We are going to give you a framework for choosing the missing services from our benchmark plans. We're going to talk about actuarial information that we've gotten, and then we're going to turn it over to you for discussion. And I have some proposed ideas and criteria that you could use. For for all of you who were here last time, I had suggested that this topic might be ready for a decision as early as this meeting. But since that time, we've received new questions and answers from the feds, which followed up from that guidance that we discussed last time that we received in December 2011. And it became apparent from the responses to some of the questions that the way people were commonly reading the guidance wasn't exactly the way that the feds were necessarily going to go. So in some ways that Q&A introduced additional confusion into the process. So I would not recommend that you make a choice today, because I think there's additional federal guidance that we will be getting, and you very likely, if you made a choice today, might have to revisit that choice based on new guidance. So what I am hoping that we can discuss today is which plans we should do the analysis on, so that we know what you would be looking for moving forward. So again, we went over this last time, but as you know, there's the benefit development is different between the exchange and the universal Green Mountain Care system, in that the exchange is very federally driven. There's lots of federal rules, there's limited state choices, and it's federally defined. In Green Mountain Care, because we would be getting a waiver from the exchange, there's a lot more flexibility. So the approach that I would suggest is that we really talk about these as two different things, so that you can think about creative approaches moving forward with the universal system.
Can I just ask one question on that, Robin? In the final reg around the waiver that was released last week, how specific do they get about the kinds of benefits you would have to cover under an alternative?
They don't get very specific. You have to show that you cover it. The coverage would be at least as good. Yes. So I think we still have a lot of flexibility there. Again, just a refresher of key dates. We were hoping to pick a benchmark plan now. That's, as we just discussed, probably premature. We'll continue to research and develop plans, do consumer focus groups, and I'd love to have draft plan options to you in May. It may not be, if we're doing it on multiple plan designs, it actually might be too aggressive, because we basically have to do the work multiple times with multiple benchmarks. And then in terms of the Green Mountain Care benefit package, for that track, we would need to have something to cost out for the financing plan due in 2013, but I see that as sort of a process that will move forward aggressively on this exchange stuff and then start in the Green Mountain Care stuff next. So what are the questions that you will need to think about? Which benchmark plans should be used to design the exchange plans? Again, I'll ask you to discuss this at the end, but just so you have the questions in your mind as we move through the information. How much specificity would you like in the exchange plan designs when we come back to you with those? How frequently do you want updates while we're doing the analysis? And beginning to think about, since you don't have to necessarily make a decision today, what criteria would you use to pick a benchmark plan? So with that, I'm not going to go through the criteria now, but I'm going to switch slides and move to the ballot slides. So this will just take 1 minute.
So the ballot ones are the black and white.
Yeah.
Everybody's reference.
Yes. Voila. So what I'm going to do is walk through these slides with you with Kate as my backup, since she's on the phone. So Kate, feel free to jump in with additional information as you see fit. Okay?
Absolutely.
Great. So we're going to walk through the review of the essential health benefits, update you on benefit restrictions, talk a little bit about prior authorizations as you requested last time, focus in on those missing services and categories required by the ACA, and then just touch briefly on a standardized summary of benefits that are coming out, that's coming out from the feds, because it'll give you a sense of what the consumer will have for information. Thank you. Here, does this help if I get closer? Yep. I can also turn it up. So at the last Exchange Advisory Committee and at this last meeting, people were interested in getting more information about benefit restrictions, about prior authorization, and the options for supplementing plans when categories are missing. And as I mentioned earlier, since then we've received the Q&A from HHS. So we'll highlight updates as we go through. So again, the review is the federal essential health benefits will be defined by a benchmark plan which is selected by the state. And then the plans offered in the individual and small group market have to be substantially equal to that benchmark plan. So they don't have to be exactly the same, they have to be substantially equal. One update that corrects something that I said last week that turns out not to be correct is that the benchmark that you choose in 2012 will apply to both 2014 and 2015. I thought it only applied to 2014 when we were last here. The Q&A clarified that. So it's a 2-year decision. And just to review, what are those benchmark options? The potential options in Vermont, here are listed 2 of the largest small group plans. One is offered by MVP, and that's the preferred exclusive provider plan. And the other is offered by Blue Cross Blue Shield, the Blue Care plan. And then the largest HMO is also at Blue Cross Blue Shield, and the way Blue Cross structures their benefit plans, the covered services are consistent across the plans. And then the third plan is the state employee plan. We did not, as we discussed last time, look at the federal employee health benefit plan because some of our state insurance mandates, which we are required under the state law to cover, are not included. So if we chose that plan, the state would be on the hook for paying for those mandates. One update is that that HHS will give us a list of the top 3 small group products which they think are the top 3. So once they give us that list, we'll also have to true that up with our own information to see if we're consistent. So under this approach, the plan must be substantially equal to the benchmark plan, both in the scope of benefits and limitations such as visit limits. But again, that's substantially equal to. So a plan could substitute coverage within those 10 statutory categories as long as the substitutions are actuarially equivalent, and that exact process is defined in the Children's Health Insurance Program regs. We didn't provide those. We can get those to you if you want that level of detail. But basically, there's an existing way in federal law to determine whether or not the substitution is accurate. And this, actually we did give it to you. I forgot that we had this slide. This slide summarizes the CHIP regulations in terms of the process for determining equivalence. So it would rely on an actuarial report that uses a federally defined standardized set of utilization and price factors and population, applies the same principles and factors in comparing the value of different coverage, doesn't look at different delivery methods or cost control or utilization, but takes into account the ability of a plan to reduce benefits by increasing the actuarial value of health benefits offered that results from limitations on cost sharing. So
this is within one of the 10 categories. What's an example of one of the categories? I don't remember.
So an example, it would be, I think do we have the 10 categories here? Well,
We got it last time, I know.
We have them
Prescription
here.
drugs.
prescription drugs or ambulatory services. So I think the gist of this is when you're looking at the benefit restrictions between plans, just keep in mind that you're not, if you pick, let's say, the MVP plan, and the MVP plan has a visit limit of 10 visits, that doesn't mean that every single plan in the individual and small group market is going to have 10 visits. It means that the plan has to be actuarially equivalent to the coverage in that benchmark plan. So there is some variation that's allowed under the federal law. Okay, so just because, to give you a sense of, like, we're getting really into the weeds on the plan differences, but to some extent you have to step back and remember that if there's something you particularly like or don't like about a plan, is picking that plan really changing what you like or don't like about it, right? So the plan may have the flexibility to not do what you think they're going to do by picking a particular
So
plan.
within ambulatory services, they could cover more PT, but have more restrictions on mental health, and as long as that was actuarially a balance.
I think it's within that band. So they could have more restrictions on one ambulatory service and less restrictions on another, and as long as it works out the same actuarially, then that'll count as being substantially similar.
Thanks.
How am I doing, Kate?
You're doing great, and the next slide actually goes into a little more detail about this.
Excellent. So the specific types of restrictions, as we just discussed, matter less than the overall amount of restrictions. And here is one example from HHS. So if a plan could be consistent with the benchmark plan if, for example, it offered 20 PT visits and 10 occupational therapy visits. So let's say the benchmark plan has 20 PT visits and 10 OT visits. And a plan offered in the market could be substantially similar if they offered 10 PT visits and 20 OT. So you don't, again, you have to be in the ballpark. So that's our review of the background. So for prior authorization, you should have a handout.
Here it is.
What Kate did was go through the plans, the 3 plans, and try to summarize for you where there were prior authorization requirements, where we didn't have sufficient information from the plans to make a determination, and where there were no prior authorization requirements. Kate, do you want to walk us through this chart a little bit?
Sure. So as you can see on the left-hand side, on the left-hand side of the handout are the various categories, the services that one of the 3 plans requires prior authorization for. And then you have the, you can see whether MVP, in the first column, whether MVP requires prior authorization for that service. In the next is the Blue Cross Blue Shield, the Vermont plan, and in the final column is the state plan. If the box says it is required, that means that prior authorization is required for that service. If the box says none, that means that no prior authorization is required, and additionally, that is a covered service. If it says no coverage, that means that the service is not covered by the plan, and therefore there are no prior authorization requirements associated with that benefit. And then the final category is no information available, and that was because we did not get a response from the plan with regard to that particular service. Some of the boxes contain some additional information regarding the way that the prior authorization requirements are used with regard to that service. So for example, let's see here, under chiropractic visits, MVP requires prior authorization after 8 visits, but not before those 8 visits are completed.
Thank you.
You're welcome. Do you have any questions?
I think people are digesting a little bit, so why don't we pause a moment to let people digest the information. And basically, it's a lot of information that gives you sort of a snapshot of requirements. And as you can see, we don't have full information from Cigna on the state plan, so that's something we can continue to try and shake out of them as we move forward.
One thing that came out in the public advisory committee meeting that might be useful is to talk a little bit maybe about why prior authorization, what's the use of it, besides the fact that many people think it's to drive practitioners crazy, but what are the reasons for prior authorization?
So at the Exchange Advisory Group on Monday, there was some discussion about prior authorization, and some of the insurers And I'm sure they would happily discuss it with you directly if you wanted to take additional testimony on it at another time. They explained from their perspective the usefulness of prior authorization in terms of sometimes using it as a check-in on the use of the service after a certain number of visits, as basically a method for the insurer to get additional information from the provider. So in addition to having it as a tool for management of care, I think some insurers also see it as a tool for information gathering, in a sense. Do you think that's a fair summary of?
Well, they made the point that in some cases, it's good practice from their point of view. For example, in step therapy for different medications, to start with one and see how the person does, and then to progress to the next, and then to the next. So that it might look like an obstacle or a hoop, but from their point of view, it would be a quality issue in terms of the progression of care.
Yes. So if there's any additional information we can get to you about this, or if there are particular questions you have, please let me know. And we can.
Well, we have no information on Cigna,
Yeah, we'll continue to ask them for that.
so there's no way to compare.
Yes, you can only compare the MVP and Blue Care
Does that information come from Cigna or from the Human Resources Department?
from Cigna.
What would be the procedure if we didn't get it? We needed to figure this out.
Well, if I were you, I'd ask them to testify on it.
Okay.
I mean, I'm sure we can get it from them. We will, we've been doing this on a very tight time frame, so we did
Okay.
not give people very much time. Your last meeting was 2 weeks ago. We basically gave them a week to get it to us so that we could get it in this format to get it to you
Okay.
within 2 weeks. So to be fair to Cigna, there hasn't been really a lot of time to be responsive, so it's very possible that with additional time, we'll get the information.
But this is very, very helpful. I mean, because already you can see major patterns in requirement,
Yep.
and this is really helpful.
Thank you. So we'll continue to work with them. If we run into trouble, I can certainly let you know. We always have Commissioner Kimball on our side. So I call them up too. He usually seems to get things out of people.
And I do just want to stress, as you're looking at this, that that while it's useful to see the overall level of prior authorization that's required, again, just because there is a prior authorization requirement in the chosen benchmark plan, it does not mean that the other plans will either have to use prior authorization for that particular service or not. So they may or may not follow what's in the benchmark plan. All they have to do is remain actuarially equivalent to the benchmark plan. And prior authorization, from what I understand, Julie, perhaps you can speak to this as well, does not have a significant actuarial value associated with that.
Yes, that's correct. I mean, there may be certain prior auths that do, but a lot of the ones that we're looking at don't appear to. An example, I think, is the Cairo one that you brought up. I think one requires prior auth after 8 visits, the other one after 12. Most visits are under 8. So, again, I think it's just the health plans looking to make sure that they are aware of any outliers to see if there's another condition that they should be managing, those sorts of things, as opposed to necessarily reducing costs. So typically, prior authorizations don't impact premiums or price.
So
Not to say it's always the case, but typically.
Thank you, Julie.
just to clarify, may not significantly affect the actuarial value. So theoretically, we pick a plan, and the idea of prior authorization is still up for grabs after that pick?
Right. So
Okay.
let's say you pick the state plan.
Right.
I keep having you pick different ones because I'm trying to be fair. So let's say this time you pick the state plan. That doesn't mean that MVP or Blue Cross necessarily have to change their prior auths as long as they meet the same actuarial value.
Right.
You need
So-
a little arrow like in basketball. Possession arrow.
Yes, there you go.
But prior authorizations have very little actuarial value, so.
Yeah, and also to point out, as a process for determining the equivalence, the actual equivalence, it does not take into account, as it states in the regs, the method of delivery or the means of cost control or utilization. So the extent that health plans are even using this to control utilization costs, it still likely wouldn't be considered as part of the actual equivalent test.
So I think the point is that picking a plan based on the prior auths doesn't necessarily get you
Right.
what you think you're getting. So it doesn't control the underlying health plan behavior, given the way the feds have set up the rules. So here, I knew it was in here somewhere. So here's the list of 10
Thank you.
that the ACA requires. And you'll remember from last time that there were 4 areas that all 3 benchmark plans, that there was at least some missing services in one of the benchmark plans, and those are in habilitative services, pediatric oral, pediatric vision, and prescription drugs. And with prescription drugs, they all offer prescription drugs, but MVP and Blue Cross offer it through a rider, and the federal Q&A says you don't look at riders. That's another change that came out in the Q&A from the guidance. So they're looking at the main coverage package, not any additional benefits added through a rider. So that's why prescription drugs is on this list, even though I think all 3 carriers offer it. So the HHS update, as I just said, is that when you want to supplement, you can't supplement with a rider, which is what we were thinking last time. You have to supplement by reference to another benchmark plan option. So we're going to go through each of these categories and talk about how that works. So again, this is the summary. So for pediatric vision, there are limited benefits included in Blue Cross and the state plan. Habilitative services, because that's not a term that's commonly used in our insurance plans, those services are probably not included depending on how defined federally. Pediatric oral, not included except through riders, and prescription drugs, it's only included in the state plan. So presumably, regardless of which plan you pick, you would supplement prescription drugs through the state plan potentially, or I think there's an option of a federal option, and we'll talk about that in more depth. So let's talk about the vision care. This is the coverage offered by Blue Cross Blue Shield and the state plan. You saw this slide last time. Blue Cross offers 1 annual exam. The state plan offers $100 towards the use of vision services every 24 months, and that can be used towards lenses. But under the ACA, there will be no benefit dollar limits allowed. So it's not entirely clear how the state plan benefits could be used to substitute. So that's an ambiguity that's not really clarified by the Q&A or the guidance. But what the feds have said is that if the plans are missing pediatric vision care, HHS, they haven't finalized this. You'll see that a lot of considering proposing, which is why we won't ask you to make a decision today. HHS is considering proposing that the state would supplement the plan with benefits covered in the federal employee dental and vision insurance plan with the highest enrollment. So they're basically picking which Lego will fit in that missing block. And they're picking it looks like what they've said is they're probably going to pick the federal dental and vision plan. So there's no state choice there, probably. For habilitative services, again, it doesn't look like we'll have a state choice in that area. HHS in their update says they're considering 2 different approaches. Either they will require the plans to offer particular services for habilitative needs as it offers for rehabilitative needs, and offer them at parity. So that's one approach. They'll say to the plan, whatever you offer for rehabilitative services, you will offer for habilitative services. Or they'll leave it up to the plan to decide how to define that, and then the feds will review and approve. So under either approach, the plan is required to do it, and the feds are deciding how that works. We did ask the carriers to give us information about how they either would or do think habilitative services would be defined. So we've included those definitions for your information. We collected one from MVP and one from Blue Cross. I'm not going to go through them in detail, but you have them for your information. And the state plan doesn't currently cover habilitative services, and we weren't able to get a definition from them. In terms of pediatric oral care, there is a state decision here. So all of the plans are currently missing services in pediatric oral. The HHS is proposing that states would supplement the benchmark plan from either the Federal Employees Dental and Visual Insurance Program, dental plan with the largest national enrollment, or the Children's Health Insurance Plan. So we have the dental coverage in Vermont's CHIP program on the next slide. It's quite comprehensive. It's identical to the coverage in Medicaid. And you can see the list of services that the CHIP program offers. We need to still collect the information on the Federal Employees Dental and Vision Insurance Plan, dental plan with the largest national enrollment, so that you have something to compare it to. But we gave you half the equation, which is the CHIP.
And if you chose the CHIP option and yours is a particularly expansive definition within the state, the feds pay their share of that.
Yes. Yep. So if they're giving it to us as one of the two choices, then yes, it would be included. It would be the federal definition for all services. For prescription drugs, your state options would be looking at the state employee plan or the federal employees health benefit plan to plug in that Lego piece. So the way that the prescription drug comparison works is if the benchmark plan offers one drug in a certain category or class, then all the plans in the small group and individual market must cover at least one drug in that category or class. It does not have to be the same drug. So there's still flexibility at the plan level, insurer level, to do their own preferred drug list, but they have to use the same categories and classes as in the benchmark plan that you pick. Now, the feds have said that the drug category and class list that they will require will be provided by one of these three standards, but that's not available yet. So that's the other reason why a decision at this point is premature, because we don't have the federal information to know which drug category and classes are required. So once we get that information, we can compare it against the state employee plan and the federal employee plan to give you a better sense of what that looks like.
Robin, at the risk of interrupting your flow too much.
Totally fine.
This process of clarifying and getting definitions, do you have a sense of time?
Well, we are required to pick a benchmark plan by the third quarter of 2012.
Okay.
So hopefully they'll give us clarity before then.
Thank you, Robin.
I'd like to get the clarity before we have to pick, but I think they're probably working on proposed rules,
Right.
but they have not given us any sense of timing on that.
Okay, all right.
So I'll let you know as soon as I know. So again, this is a summary of the essential health benefit decisions that will be before you. You need to select a benchmark plan. You then would select a pediatric oral plan to substitute the lack of coverage in the benchmark plan, and you would select a prescription drug plan. Habilitative services and pediatric vision will seem to likely to be defined by the feds. Given the state of the guidance right now, those two, there's no state choice. Those will be included in the plans, but there's no state choice. So shall I try my analogy and you can tell me if it works? All right, so I have two different analogies going, but I'm going with the tree one. Al likes the Lego one, I think, but I have a tree one and a Lego one. But the trees, you are picking between a beech, a maple, and a spruce tree. And that's what you get to pick, a beech, a maple, or a spruce tree. Now the plan might design a
I think
beech.
they should all be hardwoods.
Okay. I like if the plan picks the beech tree or the maple tree, I don't care which one. Let's go with
Why are you
maple.
so against spruce?
I love spruce trees. I'll get to them in a minute.
All right.
If the plan picks a maple tree, it doesn't mean, if you pick a maple tree, it doesn't mean that Blue Cross is going to have a plan that is exactly like your maple tree. There may be a different number of leaves, they might turn slightly different colors in the fall.
What? I don't care what we do with healthcare, but don't mess with foliage. No one brought that when I interviewed for this.
But again, what you're saying is your tree has to look substantially like this maple tree. Now, our maple tree is missing a couple of things that the feds say we have to have. For example, we need to have some tinsel. And we need to have some sort of little other decoration on there.
A bucket.
A bucket. Yeah, we need to have a tap and a bucket. Now,
No, this analogy doesn't work.
All right. So at first you all thought she put Al in the corner with a box of Legos. That's what everyone was thinking.
all right, but you get the gist.
Yes.
We gotta pick some tinsel and we gotta pick some buckets to stick on our maple tree, and then the plans will make their own tree. I won't go for the Lego, that's enough for now. So I wanted to give you some information from the Exchange Advisory Group meeting. We presented this information to that group. We didn't ask them for a specific recommendation since we weren't going to ask you to make a specific choice, and because of the moving target at the federal level. I did ask them to give me some sense of moving forward, if they had any strong feelings around what we analyzed. I would say for the most part, people didn't feel able to answer that question. And I say that, or I shouldn't impute intent, but not very many people answered that question. We had 5 or 6 people who said, expressed a preference for doing a comprehensive analysis with all 3 benchmark options, MVP, Blue Cross, and the state plan. I specifically said to people, I'm hearing that there are some people who want clarity on what the plans will look like, and they want that now. And there is a tension between having certainty sooner and a comprehensive analysis of 3 plans. Because of course, doing the analysis on 3 plans is 3 times the work of doing the analysis on 1 plan, which is totally fine. We have the federal money to do it. It's not a cost issue. But there wasn't really any clear discussion in that group. So I don't feel like they expressed a clear preference, but there were 4 to 6 people, I would say, who expressed preference for comprehensive analysis out of 35 or so. Do you think that's a fair representation? So there was some other discussion about other information that people would like. And we are getting them specific information around mental health and substance abuse, because that was a request. We also said if anybody wants other particular services at a very detailed level, let Lindsay know, and she will make sure that we get that information out to people. And that goes for you as well. Any, if there are particular things that you feel like you want to delve into, just let us know. So, I think that doesn't give you a whole lot more to go on, but that's a reaction that we got from the Exchange Advisory Committee.
And when do they meet again?
Do you know, in like a month probably?
Yeah.
And this was the second meeting.
Yes, so they met 2 weeks ago.
Right.
Before your meeting last time. So they've met twice. It's a lot of information to digest, and people are trying to think about it from their own perspective. So I'm hopeful that at our next meeting we might get more input after people have a little more time to think about it and digest it.
March 19th.
Okay, so, and then I just wanted to close this part of the presentation, and then we'll move on to Julie's actuarial analysis with some information about the standardized summary of health insurance benefits that is required under the ACA. There were 2 forms released on February 9th, drafted with the assistance of NAIC. The summary of benefits includes information on cost sharing. It includes information by category of service. And there's a uniform glossary of benefits. And if you'd like to see those forms, we can make sure you get them if you don't already have them. So that's just that would give you more of a visual of what the consumer would get for information about the. All right, so now we're going to turn to Julie's presentation around estimated pricing impacts of the benchmark options. So Julie, I'm going to turn it over to you and not try to play actuary.
Okay. Come on, it's fun. All right, I assume everyone has the slides in front of them?
Yeah.
So ultimately what we're trying to do in looking at the benefit differences is to understand what the cost impact will be. So if there's a richer benefit or a richer plan that's chosen as the benchmark plan, that might increase premiums for the rest of the small group individual market if a less rich plan was chosen. So we're trying to understand kind of what the cost impact would be of choosing the different benchmark options. Ideally, we would do this price comparison using detailed Vermont claims data. We just got access to that data today, so that has not been incorporated yet. But one of the reasons it's good to use Vermont data is that, if there's a limit, for example, like 30 PT visits or physical therapy visits, one plan has that, another plan is unlimited. We can actually go on the data and see how many members use over 30 physical therapy visits in a year, and so we can actually base it on real Vermont data. Right now, it's based on actual judgment and just industry data, and industry data is good, but there will be changes. We don't know who has what benefits, so that impacts things. Different provider practice patterns, different cultures impact things. So using the actual Vermont data will be very helpful. So that's still forthcoming. So the goal of this analysis, and I probably can't caveat it enough, is very high level and just really to estimate the magnitude of the benefit differences. So are we talking about 2%? Are we talking about 4%? So really just trying to get kind of a more of a high level understanding of what the benefit differences are. So the two plans that we've compared in the presentation that are in here are the MVP, the two small group plans, MVP, EPO, and the Blue Cross Blue Shield HMO. We have, since this presentation was put together, finished the state analysis. So to the extent I can, I'll throw in what those numbers are as well, so you have that information.
And Julie, I'm just going to jump in 1 minute to say we'll update the presentation and we'll get you the updated presentation when we have it.
Yep.
Thank you.
So we used the information that Bailiff provided. They actually provided a very detailed Excel spreadsheet that had over 500 detailed benefits. I appreciate all of their effort that went into that because it had to be time consuming. And then we supplemented that information with the presentations they provided, such as today, that had some summary information in it as well. And then Blue Cross Blue Shield actually just provided some additional input that we incorporated into our benefit comparison. Out of the 500 plus detailed benefits, over half, we don't know what the benefits are for one of the health plans. So just a caveat, and so we didn't include those if we didn't know what the benefits are. So just a caveat that over half the benefits kind of aren't included in this analysis. So one of the steps we're going to take for the more detailed analysis as well is to make sure we have all the information for any of the benefits that we think might have an impact. So we're going to go through the list of 500, pick the ones we think will be most impactful, and make sure we have all the information from all three of the health plans. The analysis also doesn't evaluate the increase in benefits that are required under the essential health benefits, but may not be included in small group. Facilitative services is an easy example because it's likely not included in either of the plan. Also, oral care is covered under like one of the under the plans for maybe certain disorders, but it isn't going to meet the requirement. So there might be a subset of it that's in it that there may still be additional costs to add in the full benefit that's needed under the requirement.
Hold on just a second, Julie.
But the impact of those things would be uniform across the plans.
So the question, in case you couldn't hear, is the impact of the benefits that aren't currently included in any plan would be uniform across the plans, right?
It should be, yes. It will vary based on, cost sharing and maybe provider networks and things like that, but generally just benefits speaking, yes, it should be roughly the same for all plans.
So basically, if I can just see if I understand it by summarizing, the thing to keep in mind when we get to the percentages is that it wouldn't be accurate to say the plan cost will increase by 2% because there are additional costs from these additional benefits that aren't included in that. Is that
differential?
It's really looking at using it as a comparison among plans to see the differential of coverage. Is that accurate, Julie?
Exactly. So yeah, we're right now just comparing the benefits between the plans, not necessarily the full impact of all the different potential health benefit requirements. And one thing I realized was in the last meeting, and I forgot to follow up, is maternity required under your individual product?
Yeah, everyone has to be pregnant. That's
That's a rule.
I'm looking for.
that's why 14 out of 19 people in the room are female.
Yes, it is a state mandate. So
Okay,
yes, I
good,
think.
The gallery.
I meant both the state mandates, because that's, many states don't have that included, and so, you know, I wanted to make sure when we talk, because we're kind of looking at comparing small group plans, but to the extent that individual doesn't cover some other benefits, but if they're all state mandated, it should be fairly equal across both markets. So
Yes,
just wanted to-
my understanding is that our benefit and mandates apply across both markets, if not all markets. I think they apply across all
Like
markets.
all markets.
Okay, moving to slide 5, if there's no other questions. So we took the benefit differences, all the detailed benefit differences, and we grouped them into categories based on our expected, again, this is expected impact to premiums. So we bucketed them based on if they're highly significant, if they're going to increase premiums by 0.1% or more, moderately significant between 0.05 and 0.1, and then slightly significant at 0.05 or less. Note we actually did this grouping right when we started looking at them, and as we started digging into some of our industry data, a lot of those shifted places. So again, just supports the fact that this is really high level at this point. But if anything, I think anytime we've used actuarial judgment, we've erred on the side of conservatism, so that our numbers aren't going to be increasing, but if anything, they'll be coming down. So when we did that side-by-side comparison, you can see in the table that MVP EPO has about 38 different benefit differences in total, while Blue Cross Blue Shield HMO has 45. Although the majority of MVPs are either insignificant or are prior auth, and only 3 are considered to be slightly significant, where Blue Cross Blue Shield actually has 19 more than MVP, or 22 total that are considered to be slightly or moderately significant. In taking then these benefit differences and trying to apply a price impact, again, as I stated before, we used industry data, but many were also based on actuarial judgment, where we couldn't grab any data, or the data didn't seem reliable. The impacts for these were estimated by considering the benefit independent of downstream effects. I think actually the better example than the one I have in here is the state actually covers infertility treatments. So when we looked at the state benefits, we really just looked at the cost of covering infertility. However, if you cover infertility, there may also be an increased incidence of multiple or premature births, which tend to be more costly. So we're only looking at the cost at this point of increase of the difference in the benefits. When we do the detailed analysis, to the extent that we think it makes sense, we'll try and see if there are downstream effects. But for now, we've only included the cost of that actual benefit. And as we discussed, prior auth differences are not included in the pricing impact. Mainly it's a procedural and typically doesn't impact pricing. So the pricing difference for the MVP and Blue Cross Blue Shield plans, excuse me, our estimates again are reasonable but conservative. Blue Cross Blue Shield, we estimate their additional benefits would impact premiums about 1.4%. So what that means is these are benefits we know that MVP doesn't have. So if Blue Cross Blue Shield was chosen as the benchmark plan, MVP premiums were likely to be increased up to 1.4%. And again, with Blue Cross Blue Shield, there wasn't necessarily 1 or 2 benefits that were significant in driving the impact. It was just they have a lot of little additional benefits. So it's very possible that as we dig through the data, these will turn out to be less significant and that may go down. But right now we've got a small value for a lot of those different benefits. And overall, as a percent, around MVP's 3 slightly significant benefits actually round down to 0. I think it ends up being worth a dime or so, but there really isn't much difference there. The state is impacted 2.7%. So MVP obviously is the least rich. Blue Cross Blue Shield is about in the middle at 1.4%, and the state's at about 2.7%.
Julie, since
on
we
a
don't
PM
have
PM
Julie,
basis,
hold on just one second.
this is, oh,
Lindsay,
since we don't have the visual 2.7, maybe she should just say it again so that the room gets it.
right, so these slides haven't been updated with the state employee plan, so just to summarize again, if you added a third column on this chart on slide 7, the state total differences would be 2.7%.
and I do believe, and I have to confirm that most of those are in the highly significant. They've got a few benefits. I think infertility and vision might be the 2 key ones that are fairly significant that the other 2, the small group plans, do not have. And looking at the price impact on a PM-PM difference on slide 8, this PM-PM will differ for many things. For high deductible plans, it will likely be less. For plans with minimal cost sharing, it may be more. And then it's just going to vary based on health plan, network, all sorts of things. But this is just to give you a rough idea. So assuming is there a question?
No.
Okay. All right. Assuming a per member per month premium of $350, the Blue Cross Blue Shield HMO benefits would add a little under $5, $4.92 to a health plan's premium. Conversely, MVP, like I said, is very small at 13 cents PM.
So just to understand the differences in these versus the public advisory meeting, that's because there was an error in one of them that's been corrected?
Yes.
So these are the updated numbers without the state comparison?
Yes.
And I think if the question is regarding the presentation that was on Monday, numbers have been revised. Blue Cross Blue Shield provided us several updates to their benefits, and so it impacted actually both the MVP and the Blue Cross Blue Shield numbers.
Do you have a number for the state for the
Do we have an
slide
yeah.
7?
Good question. Okay, very high level, it will probably be around, and don't quote me on this number because I can guarantee you it will be different in the PowerPoint, but it will be around $9.50. Somewhere around $9.50, give or take a quarter or so.
Great. Okay, I think any other questions on this slide? All right, keep going, Julie.
All right. So next steps, again, this is a very high level review. We'll incorporate, the first thing we're going to do is incorporate the state into the benefits into this PowerPoint so that you can see the full comparison of all of them. As I stated, the state impact is 2.7%. This is driven by infertility, vision, and then the state also, where the small group plans often do have limits on the number of services, the state virtually has no limits on any of their services, so that can have a notable increase as well. So I think those are the 3 main drivers in the state increase. As I mentioned, we did receive the data as well, so that we're going to start looking at the VH-Cures data that we can use for Vermont-specific data and actually pull data for these specific plans as well. And then we're going to get the health plans to verify their benefits as well. And I'm hoping if we can get the health plans to verify their benefits and that we can finish the detailed analysis in about 3 weeks. But a lot of it will be depending on the timing of verifying the benefits.
So is it fair to say that it's not the numbers that are important here yet, that this is a process and a picture of how we're going about it, and suddenly the potential value of VCures?
Yes. Yes, I think
Yeah.
definitely you should see the numbers as giving you relative
Yeah.
comparisons between the three plans and not get fixated on the exact number, because once, as Julie said, once she delves into the Vermont specific data, those numbers will change, because right now they're based on high level data and not the specific usage by Vermonters.
Con, I think there's something else, and that is that in the 15 years that I bought health insurance, in the last 15 years, I never knew any of this. So I was buying a product that I didn't know how fresh the apple was, or the condition of the tomato. And what's interesting of critics on both sides of the political aisle of picking a benefit is what do you want it to look like, and then do you understand what's under the number? Because we bought based on basically price. I mean, so that's what I find fascinating about what you've shown me over the last couple of weeks. So you're doing great.
Yeah, I should also mention that one of the things we're going to include in the detailed analysis as we look into the data is we're going to try and quantify, and I think that we alluded to this a little bit on in the meeting on Monday, is how many people really use these benefits that are additional. So we're going to try and capture that information. So how many people actually use this additional benefit, and any kind of range in services as well. Did they use it once in the year? Did they use it 10 times? So we're going to try and capture that information so in case that's helpful in understanding, if benefits actually, how many people it's going to impact. Type of.
We're getting lots of nodding. Yes, that would be interesting and helpful.
Okay.
Do you want to summarize your caveats, or do you feel that you've covered them?
It's an actuary's job to caveat everything, isn't it?
You sound like a
Here's our
lawyer.
numbers, but don't pay attention to them. Just pretty much again, I think probably things that we're still waiting for HB guidance that could impact things. Benefit differences, if the carriers come back and alter the benefits, things may change. So again, just the numbers are subject to change, but hopefully I would be surprised if we think the state's the richest, Blue Cross Blue Shield somewhere in the middle, MVP's the leanest, and I would imagine that the percentages will probably go down a little bit for each of the state and Blue Cross Blue Shield, but we'll see what the actual numbers produce for the data.
And then there's more detail that is included in the appendix that we won't walk you through, but you have the list of detailed benefit differences for your information. So now I'm going back to my PowerPoint to wrap us up and turn it over to you to discuss. So in the last meeting, Bailiff came up with several different criteria that you could use to evaluate a benchmark plan. I'm on slide 7 of mine.
Page 4.
Page 4, sorry.
The green headline is broad.
Oh, that's got the wrong church.
Green. So what I tried to do is sort of flesh that out a little bit with a little more information just to get your thinking going. And of course, these are just suggestions for you to consider. So one question you could ask yourselves when you're evaluating the benchmark plans is, what should the exchange health plans look like in 2014? And
Should that be 2014 and 15?
2014 and 15,
Yeah.
yes.
Okay.
So in 2014 and 15, under at least the way H559 came out of the House, the plans will include individuals and small businesses with 50 employees or less. So those are the folks that this essential health benefits impacts. So not folks who are buying insurance or get insurance in the large groups, so larger employers, not Medicaid beneficiaries, individuals who don't have employer-sponsored insurance, and small business with 50 employees or under. So one thing to think about is, where do these employees and individuals get their insurance today? And that's primarily in the small group market, the association market, the individual market, Catamount Health for some individuals, and a few people who would move from the Vermont Health Access Plan into the exchange if we don't do a basic health plan. So one way to think about this is where are people today, and then how similar or different is it from what they have today, and do you want it to be more similar or do you want it to be more different from what they have today? But just thinking about it from a person's perspective, is this a big shift, or will it basically be similarity to what you have today?
And the greatest similarity would be with the small group market, because these are the most popular plans in the small group market.
Right, so either the MVP or the Blue Cross, and to the extent that Blue Cross has the same benefits across all their products, you could look at that broadly too if you want.
So VACE is the same as small group in this instance?
Yes.
Yeah.
So another question you could consider is how comprehensive are the benefits? You've gotten a little bit of a sense of the comparisons between MVP, Blue Cross, and the state employee plan. You'll get more solid numbers moving forward, but that gives you a sense of the comprehensiveness. Are there features you especially like or dislike about each of the benchmark plans? But the next question to ask yourself is, will picking that plan actually change what you like or dislike about the plan? Or because of the substantial similarity test, is it really, you're picking it because you like a particular feature, but it doesn't really impact on what is going to get offered? So just remembering that when you're kind of reacting to things you like or don't like in the plan.
On the where people get their insurance today, are you able to give us estimates? You don't have to do it right now, but of the number of people in each of those categories?
Yes, so I can do ballparks off the top of my head. Small group market, there are 23,000 employees lives in the small group market. There are about, I might not be able to pull this one off. I think there are 80,000 people in the association market, but I think only about 20,000 of them move into the small group market in 2014. The rest stay outside of this new market. Individual market, there is around 5 to 7,000. Catamount Health is around 12,000. I think individual is actually closer to 4 or 5, because I think Catamount and individual is 19 total. And then VHAP, I don't have that number on the top of my head, but we can get you all of that.
And the Catamount has to come up to some higher standard no matter what.
So the Catamount plan is not grandfathered, so it cannot be offered in the individual market in 2014. But Catamount, the actuarial level would put it in the gold range, so there would be most likely something fairly similar to Catamount that could be offered in the gold range. And then, of course, what are the differences in the cost of the plans? Both differences in coverage, and you have those rough relative values now. But then the other thing to keep in mind is who's paying that cost. So for individuals under 400% of the federal poverty level, their premium is set as a percentage of their income. So if you pick a higher plan, that costs the federal government more. It does not cost the individual more. But it does cost individuals over 400% of federal poverty more, depending on the richness of the plan. And then, of course, employers who are picking a plan for their employees would bear, not necessarily, depending on how they split that cost with their employees. I should probably say employers/employees, because it's up to the employer to determine how they share that cost with their employees.
You also have a breakdown of where that 400% is? Like how many of the total number of folks are under 400 and how many are?
No, because we'd have to do a migration analysis to figure out how many small employers might drop coverage in 2014, and we have not done that. So we don't have, we could do it for Catamount, we could do it for, obviously, be everybody in Catamount with assistance, the people from VHAP. We could do it that way, but it wouldn't be.
Assume everybody sat still.
If we assumed everybody sat still, we could probably come up with something. But it's roughly 2/3 of Vermonters on a broad basis fit into that category. Not all of them will be in the individual and small group. And then a last potential criteria you could use is, does it matter as a step towards Green Mountain Care? Green Mountain Care is required to have coverage, at least the same coverage service as Catamount Health, which is an individual market product. So any of the three benchmarks will likely meet that. Something most similar to Catamount, because it's offered by Blue Cross and MVP, either of those products are likely the same. But there are other groups who will be moving into Green Mountain Care in the future who have richer benefit packages. Do you want to move towards their standard? Would you do that in the first 2 years of the exchange? Is that later as in the staging? But and none of that has a precise answer, but just to throw that out there to start thinking about how do we this as a transitional step.
And those would mainly be union plans and Medicaid?
Yes, I think so. We haven't done a comprehensive analysis, but my gut says it's state employees, teachers, perhaps some other bargained plans, and Medicaid. So then back to our questions. Which, and I don't, it's up to you how you want to proceed now with your discussion, but it would be helpful to get some sense from you of where you fall out in the tension between speed versus certainty. And then also in thinking beyond these benchmark plans into the cost sharing analysis that we will be doing. There's a range of ways we could do that. We started to talk about this last time. How specific are you looking for? Getting a sense of how frequently you'd like updates, or we can do that ad hoc if you don't have a set preference. And then I think you could discuss now or later what criteria you would use.
I'm for speedy certainty.
Have your cake and eat it too.
What are the steps that you would take in terms of plan designs once we make the choice? What do you do next?
So, and probably Julie could talk about this in much greater detail than I can, but at a high level, she described the actuarial analysis that would need to be continued around the benchmark plans to really boil down into the cost differences between those three. The other part of that would be if you wanted more specific plan designs, like you wanted to have certain deductible levels and cost sharing levels presented to you, as opposed to at the silver level, here's a range of premiums, at the gold level, here's a range, at the platinum level, here's a range. You can either get information at that level, so premium ranges by actuarial level, or you could get actual plan designs like $2,000 deductible, 20% coinsurance, $25 copay. I'm just pulling that out of the air, or $500 deductible. So it really could be anywhere in that range, and depending on what we were doing, would be more analysis or less analysis, right? So it's primarily an actuarial analysis, and I think if we were getting into cost sharing design, I think we'd want to look at any of the research that's out there around how cost sharing impacts on consumer behavior, and really be thoughtful about that. So that would take some time as well to delve into.
Any questions? Other questions?
And then you'd have to cost out each of those options.
I think my only question is, when are we thinking we'll get back to you on any of these questions, or when do you know?
Well, I hope you'll give me some sense of these questions today, just general. It doesn't have to be, you can change your mind. I just want to I mostly want to have a check-in to make sure that as we proceed, that we aren't going to come back to you in a couple months and you're going to be like, what? That's not what I wanted this.
Yeah.
And
So-
when you say slower, how much slower?
I haven't really explored that very clearly with Julie, so maybe Julie, you can jump in. So what I'm thinking is that my assumption is that if you are creating, let's say we we want to have 12 plans offered in the exchange. 3 at each.
At all
I didn't hear the
formats.
question. Can you repeat it, please?
Yes, so we're trying to get a sense of how, if we do proceed with an analysis using all 3 benchmark plans, and we want to get to actual plan design, like with deductible levels, my assumption is that doing that with 3 benchmark plans will take longer than doing that with 1 benchmark plan, because you're costing out, let's say, 9 to 12 plan designs. If you're costing that out with 3 different plans, you're actually talking about 3 times that many plans.
Yes, if we wait until we've already narrowed it down to the 12 plans, it probably wouldn't be a significant undertaking, but if we try and do it, when we're still looking at
All
a
3
large spectrum, it probably wouldn't be that bad. So.
I'm wondering if it would make sense to sort of choose the middle and know that you deviate to a slight degree in one direction or the other. When you get to the specific level, there's going to be some deviation. The overall price deviation is going to be 1 or 2% in either direction, but it's not great. And you've got the middle as the standard.
And I think we can continue to delve into the detail around these 3, so you get a better sense of cost between these 3. And then if we, I mean, part of it, it's hard to pick because we don't know when the feds are going to give us enough information for you to pick a benchmark plan, right? So at some point, it might make sense for us to proceed with the middle plan on the cost sharing analysis, knowing that there would be variation on the other side, and then we might have to do that a second time with the actual plan that you picked if you didn't pick that plan. But that may be a little more efficient, and we can certainly revisit it, because if we get the clearer federal guidance in the next couple months, then it'll be less of a big deal than if we are waiting and putting it off.
Robin, I just had a question. Does it matter if one of the insurers or all the insurers disputed the actuarial value findings of this report? I mean, what if they didn't agree with what the findings are?
So the federal guidance, I'll ask you, Kate and Julie, to correct me if I'm wrong, but I don't recall anything in the federal guidance that outlined what the process is for that. I'm sure there very likely would be some sort of appeals process that the insurers would do with the feds, but I don't know what that is yet because they haven't said. Does that sound accurate to you, Kate or Julie?
I actually had a hard time hearing the question.
Oh, I'm sorry. The question was, what if the insurers disputed the actuarial value of a particular, that someone came up with, either us or the feds? Pegged to a specific plan.
In terms of establishing substantial equivalent to the benchmark plan? Or
Yes.
in terms of the middle, the cost sharing?
Well, I
Are you
think.
talking about the AP levels? Yeah.
So I guess I'll ask Mike. Do you mean the substantially similar test, or do you mean that the actuarial levels, the meta levels?
What I mean is if in here there's some price variation across the plans based on someone's actuarial analysis, and I suppose the insurers might dispute that finding, that it's not that different or the difference is much greater. And I'm just wondering if that matters, or if that, is there a way to deal with that
So I think it's a
circumstance?
process question as opposed to any sort of legal question.
Right.
So at the Exchange Advisory Board, there were representatives of both Blue Cross and MVP there. Blue Cross asked if their actuary could chat with our actuary. I said, sure. We're trying to do this in a very transparent and open way so that if and when there are thoughts that we have information that's incorrect, they can update it and we can have an open dialogue. So we don't have a process for disagreement, but hopefully because we're trying to share all of our information as we get it, it'll...
Less likely to happen.
Right. And I'm assuming that, that makes sense. I'm assuming that similarly, the feds will have something built in when it gets to the point of whether the plan meets the silver level, gold level, or bronze level, or platinum level.
before we continue to narrow in on Vermont decision-making, can you share with us some of the other states, the nature of the other states' concerns? And some of the calls that I've listened in on, there's a lot of worry about not having the information in a timely way. Can you go through the other sorts of concerns that have come
Well,
up?
I
with the
haven't
calls?
been on those calls, but maybe Lindsay can do that. Do you feel like you could summarize other states' concerns?
I haven't really been on those calls either.
So it sounds like you should summarize them, Karen.
Don't mess with Thomas. Just a
So Lindsay
footnote.
said, for the purpose of recording, that she is not sure. So if you have ideas, Karen, you should summarize them.
No, I don't think I'm in a position to really go through it systematically, but I guess my impression is there's an unbelievable level of confusion because of some of the lack of specificity around some very important decision points. So although people are certainly not at the level that Vermont is in terms of having the exchange as a stepping stone to a whole other way of thinking about the new Green Mountain Care, nonetheless, they seem quite stymied by some of these obstacles.
Well, and I think one thing that's hard to judge is for states that are opposed to the Affordable Care Act, how much of it is actually being stymied and how much is it a political reaction? And I have no way of judging that. The other thing that I frequently find is, and maybe this is because I'm a lawyer, when I read the statute, it seems perfectly clear to me, and other people don't read the statute and it seems very confusing to them. So I often feel less confused than other people express on calls. So, but I think your general point is right, that states in general, in the whole Affordable Care Act in general, want more information. And the feds, I think, are trying to get that information out as quickly as they can, but it's a big act and they have a lot of work to do. So I think they know that this is a priority and that they need to get us something sooner than later, but I don't know what that means in terms of when is sooner or later.
I just wanted to, hello.
I'm Lindsay Tucker. I just wanted to confirm, Karen, that there are other states who are also working to implement state exchanges and are excited about the opportunity of implementing state exchanges that are grappling with these questions and the timing and the implications of that. So I can't give you specifics, but we are not the only state that is going through these hurdles.
Well, let me explain the underlying reason that I was interested in that question, and that is we are new and unique. And so I'm sort of wondering if there are other states with a comparable Green Mountain Care Board and how they're going about looking at the questions that we are struggling with.
Well, most states have actually set up their exchange with a board. And so I assume that the board that runs the exchange would be the place where they're considering these questions in other states, but I haven't been tracking it closely.
Yeah, I haven't been following it closely, their decision-making process, but that would be my guess too. And how much of that is done at the staff level versus the board level, I don't know.
Yeah, I mean, places like California's as a board, they've been doing a lot of work. Rhode Island, Maryland, we could check on it and find out what the status is.
Yeah, I just wondered, at least my understanding was that those boards are not so independent as that they are
Depends on
more
the
like your
state.
public advisory board, which is there for
No,
input
no.
and not,
No, in some cases, they're wholly non-governmental.
okay.
And totally separate. In some cases, they're quasi-governmental. It depends on the state, and they have different appointment processes depending on the state.
Okay.
Can I?
Go ahead.
You said we're young and unique. My
Some
kids
of
tell
us.
me. My kids tell me I'm old and common. And these prove it. To give you feedback on your questions, just from my brain, and this isn't the board, this is just me. It seems to me like I'd want to know what the highest cost and what the medium cost, because we can always pick cheap or low, whatever you want to call it. And then I'd want to know what it does look like, what the world looks like in the highest and the medium. Because there's two criticisms I hear on the radio when I come down here every day. One is that we should have already done the benefit already, and it's proof that this is a bad idea. and yet you're telling me we don't even have enough information to do the benefit. So, you know, we can't plant seeds yet because it's, you know, it still may frost. And then the second thing I hear is that it's gonna, we should know what it's gonna cost, right?
Right,
But if we can't make the benefit, then we can't cost it out, right?
right.
Okay, so can we make the benefit?
We can make.
Say no.
No.
Right now. Not now, right?
Not one benefit.
We don't have the
can make-
information right now.
Unless you're willing to pick one of the three without the information.
Oh, I can be arbitrary. And, hold on, and capricious.
No.
Oh, that's rate review. We'll get to that. But
So, no.
my point is that I would do highest and medium,
Mm-hmm.
and I would want to see the cost of the bucket and the spigot. But I don't know how in depth. I just kind of want to, because I wrestle with, you know, I have Professor Richard Snyder in my mind from Norwich telling me he wants a very rich benefit for competitive needs of Norwich University hiring. And then I have some small business owners in my head saying, keep it cheap or I'm going to go broke, and I wrestle.
Mm-hmm.
And so I'd kind of like to know that, but I don't know how in depth I need that. And I would open it up to anyone in the room to either debate me as wrong or to prove me right. But if somebody could call the radio stations and tell them to maybe stop.
Yeah, Al, let me take.
Alan was-
Oh, I'm sorry.
Alan was queued up to say
I'm
something.
sorry.
Well, you know, mine was along the same line about trying to get specificity around these cost-sharing designs, and you know, I guess I could do away with the minimal, you know, versus the medium and high cost sharing, but I really think that's going to be important for us to really know what costs are going to be, what costs are going to be put on the consumer, on the Vermonter, and very specifically. I get my colleagues want to know that. I mean, they want to know, well, gee, you know, how much are we going to expect our patients to participate? And this is one way of knowing how much we're expecting our patients to participate in a financial way. You know, so.
I worry about asking for everything all the time. I don't want to say I've seen that at the legislative level, but I have. And what happens is it can turn into a kind of a paralysis because you never quite get there. So I'm opting for an ever deeper analysis along the lines that Alan's talking about, perhaps starting at the level that Alan's talking about, but an iterative view that's reasonably back and forth, rather than, I use the analogy the other day of swallowing the whole pig, tomorrow, because we won't succeed that way. It has to be a mutual education process between the administration and us, and that's, so I guess to a certain extent, asking you to kind of define the next level that you're capable of getting back to us quickly, right? And then we take the next layer back and go from there.
Karen?
What I'm wrestling with is, in a sense, the relative importance of these decisions, and therefore the relative need for excruciating detail to make the decision. And I would come out more towards the higher level information with enough examples that we understand how it would work, in a sense, on the ground. So some of those scenarios that you spoke about, I think, would be very helpful and illustrative. But just to get back to the kinds of decisions that we're facing here, and to put it in the historic perspective, that this is the exchange, which is a stepping stone to Green Mountain Care. So the analogy I was thinking of in medicine is if you have to start an IV and I say, Robin, do you want your IV in your right hand or your left hand? So the question isn't, do you want an IV? And in a sense, that's the level that we are so constrained by the federal guidelines on this one, that our choices are actually very narrow, and the specificity, a lot of it is there, so that we not obsess over details when we have much bigger, and I would say types of weighty decisions coming up around benefit design and Green Mountain Care. So for that reason, I would go more towards the, let's get the information we need with some good illustrations, and make a decision, and then move on.
I tend to agree with that. All right, do we want to answer any of these other questions? How frequently do we want information? Daily? Pretty much.
3 times
See
a
what I
day.
mean?
That's right, I have her on speed dial. I'll call her 3 times a day and give her an update.
Send me a text when you wake up every
Yeah, how about I
morning.
text you?
God, no. Anybody have any strong feelings? I mean, I think Con
Yeah, I
Con
think that's a
described
good
it well.
approach.
Bring
Yeah.
it back when you have new, good information, but I don't think we need to do this
Right.
on a weekly basis.
No.
God, no.
The only thing I was going to say is that if there is big news out of HHS,
We'll let you know.
well, or even come back here, and do it this way, because, sometimes information going through email or through contacting one of us doesn't get to all of us in the same way, and then we won't interpret it the same way when we have to make a decision. So that would be my.
Okay. And on criteria, do people feel equipped to address that today? Or do you want to mull that over?
And that's really for you. That's
Mhm.
not, it's
Yeah.
helpful to me to know, so I know what additional information to focus on, but
Okay, so why don't we just take that under advisement and take it up at another time?
great.
Okay.
Thank you.
Thank you very much. This was a lot of detail today, so I think even just, even like this thing is very, very helpful. So we appreciate your work on this. And same to the folks on the phone.
Thank you, Julie and Kate.
Thank you.
Before we let them go, do we want to take any questions or comments on this particular subject from the audience?
I'll be the first.
Walter?
Throw it.
Where's the bath fees, by the way?
The what?
The bath fees that we usually put the mic in?
Yeah, I don't know.
You gotta follow the way.
First of all, I do enjoy your presentations.
Thank you.
You should be nominated for an Oscar. I don't know. I'd like to ask a couple questions from the point of view of the bucket and the spigot on that tree.
Sure.
Mobility between plans, if that's possible, just some thoughts perhaps. In-network and out-of-network problems, which I had huge difficulties with and almost cost me my life, in fact. How is that going to affect the exchanges? And what deductibles, co-pays, is to pick up on what's been asked here by the board earlier, are probably going to be.
So let me address those 3, and if you have more, that's good, but I won't keep
I'll
more
stop
in my
at 3.
head.
Yeah, I know you will.
So the essential benefit plan and these benchmark plans only address covered services. They do not address cost sharing. So that is a future piece of analysis to be done. The way that the ACA addresses the cost sharing is by those metal levels, which gives you, in an aggregate way, a sense of the amount of exposure to the consumer. So the bronze, silver, gold, platinum. At the bronze level, there's more cost sharing for the consumer. At the platinum level, there's less cost sharing. And of course, the cost sharing and the premium are related. So if you have higher cost sharing, you have a lower premium. This is very rough, obviously, and vice versa.
And there's an interplay with the cost-sharing subsidies.
Yes, and there's a whole interplay with the cost-sharing subsidies. And we haven't really focused on that because the decision about the essential benefit package is independent of cost-sharing. It's just about what is covered. And on both of your first 2 questions, because the plan that's being chosen is a benchmark plan, there's still flexibility at the insurer level. So it doesn't really definitively set one way of doing it. So for example, you pick a benchmark plan, you happen to pick, let's say the Blue Cross plan because it's in the middle. MVP will still have a plan and Blue Cross will have a plan, and people can still go between those plans and pick whichever one they want. And what they cover has to be equivalent to, substantially equivalent to what the benchmark plan is. But it doesn't, again, get into the level of detail to really address your first 2 questions.
Can you switch more than once a year?
I'd have to go back and check the regs. I think you can switch once a year unless you have certain, usually you can switch if you have certain life changes, divorce or job change or things like that. So I need to check on all the details of that.
Yeah, would that be once a year? If you get divorced, be 6 months, 3 months?
The
after
federal
that, right?
law defines that.
Okay,
There's not a state choice there. That's the feds have defined how that would work.
great, right?
All right, other questions or comments? All right, thank you very much.
Thank you.
Okay, so next on our agenda is to go back to the draft rate review regulations. And Al, are you
I am.
leading this discussion?
I think everyone has a copy of the, I would call it a red line copy, but it's in black and white.
We're saving money.
Yeah. So the process of bringing the rate review to you today, the rate review rule, is that we've had 2 stakeholder meetings and received a lot of feedback from interested insurance parties and the ombudsman. We just recently received a letter from the Office of the Healthcare Ombudsman late yesterday, so some of their concerns are not worked into this rule yet, which we will listen to and we'll get back to. The process today is to vote, hopefully, on this rule, and then begin a public process of rulemaking. And so I'm going to highlight some of the things that we changed since the last time you've seen the rule, but I'm not going to read them or go into them in depth. For everyone in the room, the rule will be on our website by now, and there are copies in the back of the room if anyone would like a copy. So a couple of the major questions that were brought up at our last stakeholder meeting. One was under the Section 1 purpose, which was if we needed to clarify the purpose to cover additional things other than requests for health insurance rates, which would be things such as factor or admin filings or trend filings. After studying the issue, we feel the way that this is written is strong enough language, and it cites the underlying statutes, and we're pleased with this. The second issue that was addressed is Section 7, which is interveners. We've, based upon feedback from the insurance companies and the ombudsman, we have changed the intervener portion of this and in fact even retitled it. And so this is an attempt to allow the process as set forth in a contested case to actually be able to be accomplished in 30 days. There is still some feedback, I'm not going to speak for the ombudsman, that may not be enough time, but we're trying to make the process as expedited as possible. And so those are the 2 major changes. There's a couple other minor changes. One was in Section 11 under B, party status, which relates to the intervener section. And that's pretty much it. So from here, if this rule is approved today, we would then begin to listen to the public in terms of what they think about this rule. And there is a process going through emergency rulemaking procedures and the normal rulemaking procedures, because we'll have to do both simultaneously. There is a process that we'll have to follow, and we can get you copies of that. So that's.
Let me just see if I understand right. The ombudsman submitted a letter yesterday. That is not reflected here. So if we were to accept any of their suggestions, we would have to do that during the rulemaking process?
During the public engagement. And a lot of what was in their letter we
had already done.
We had done, because they were at the meeting.
And just as a clarification, during the formal rulemaking process, we can make changes at any step along the way based on feedback we get through either talking with the public, the ombudsman, carriers, or even ICAR or LCAR. So we can modify numerous times over the course of the next few months for this process.
Questions for Al?
More of a compliment.
I sat in on those stakeholder meetings, and they were really open, transparent, thoughtful on all sides. So I really think that you've set a tone. Everybody participated set a tone for the future here. So thank you.
Thank you.
Any other questions for Al? So you're looking for a motion, and
I am. If we approve
move this
it-
forward, then we begin both the emergency rulemaking process.
Just the formal rulemaking
Just the
process. We do
form-
not have authority for the emergency
That's
rulemaking
right, we
process
don't.
yet. I'll let you know when we get it.
So moved.
Second.
Third. Any questions? The motion is to, Con, why don't you state your motion?
I move
Which has
that-
now been seconded.
I move that we accept this current draft of the regulation for rate review submitted by member Alcove.
And we don't have a version number, but we'll call it the version.
March 1st
uh,
version.
It would-
March 1st version.
Yep.
As reflected
Really
in
version 1, because it's
what's
the
handed
beginning,
out.
right? Public version 1.
Okay, any questions on the motion? All those in favor, say aye.
Aye.
Any opposed? All right, congratulations, Al, and Carla and Ina, and whoever else has been involved in this process.
Now we need to get together with the ombudsman and work out the rest of my highlighted stuff on their letter. Just to prove I'm not.
Keeping going?
Yeah.
Great, great, okay, thank you.
And business.
We have new business, yes. So we have one item of new business, and this is a proposed contract relating to the development of and tracking of quality and other measures for our performance dashboard. And Con, I believe, is going to describe what this is all about.
Act 48 explicitly requires that the Green Mountain Care Board construct what the Act calls a dashboard of system indicators. Now, I mean, there are millions of indicators regarding healthcare, but these are related and confined to thinking about the system, overall system of healthcare in Vermont, with a basic underlying question behind it: over time, are we making progress or are we not? That's the system measures, and I want to compliment Doreen Chambers and Mike Davis for helping us get to this particular point. But the system measures have to do with cost, accessibility by Vermonters, the health status of Vermonters, and the quality of care and overall quality measures. We have internally taken it to a certain point where we have a very clear view of what the concept on how we want to do this and the level of simplicity and the general approach. We are now to the point where we need a statistical pro to verify, to help format, and help figure out how to update the process on the web over a period of time. So in order to do that, we've roughed out through Georgia a contract with Dr. Do I mention the name? Dr. Cy Jordan, who has quite a remarkable background in this kind of work. It's a contract for up to $15,000, a very modest contract to set a kind of an important tone for the overall work that we're doing. And I'm recommending that the board approve that contract today.
And could I just add that there is allowance under this scope of work for some additional assistance related to obtaining Medicare data from CMS. And Dr. Jordan has some expertise in that, actually has an existing data use agreement under one of the avenues available to get Medicare data, so he may provide some assistance with that as well.
Just one additional note, there's some language in this proposed contract about subcontractors to provide Dr. Jordan with the flexibility to subcontract. He, however, cannot subcontract with anyone without our express
Right.
approval.
Move we approve the contract?
Second.
Do we have any questions? Any discussion? All right, all those in favor of approving the contract for up to $15,000 with Dr. Cyrus Jordan, actually, he's William Cyrus Jordan, according to the specification of work presented to us on March 1st. Say aye.
Aye.
Any opposed? Thank you.
Thank you.
That's great to get that underway. So, making progress. We like that. At this time, I think we're done with our business for the day, unless Georgia tells me otherwise. All right. And I would welcome public comment on any of the issues we've discussed today, if there's any additional. Yes, Peggy?
Oh, 1 second, please.
This is a spot issue in terms of retirement for coverage, but you've talked about dental and you've talked about vision, and Robin mentioned that specific federal plan, but I would just urge you to consider audiology and hearing as very marked issues for quality of life issues for folks in that category.
Thank you very much. Any other questions, comments? All right, thank you all.